Okay, hello, welcome back. I hope you managed to find some coffee. We're starting gently with a film. And Dr. Klaus has a video on left ventricular remodeling. Dr. Klaus, thanks. You better go down here. Take that with me.
Good morning, everybody. If you're making a video of a typical case, a typical patient, you'll find that you don't have a typical patient at that moment, especially a couple of weeks before the meeting. So you use the patient that best suits and best fits the purpose. But this was not a typical patient because it was a patient that was admitted at a hospital and was not electively operated. But I'll give you the case presentation and I'll show you the video. By the way, we have an experience of about 200 ventricular reconstructions, and about half of the patients are elective, and we've published some data on that. We will publish the entire series soon. This was a 46-year-old male patient that had 4 myocardial infarcts. The first in 2001 in the posterior wall, 2002 the second one, he got thrombolysis afterwards. Next year, 2003, again anterior myocardial infarction, which was followed by cabbage surgery, Lima to LAD, and a venous graft to the anterolateral branch, circumflex artery, and right coronary artery. A couple years later, 5 years later, he had a major anterior myocardial infarction and then started to have heart failure symptoms, MR grade 3. The next year he received an ICD, and he had several admissions for heart failure in the beginning of this year. So the current problem of this patient was that he was still admitted, after his lab admission, he was still admitted in a referring hospital with persistent heart failure symptoms. They did not want to discharge this patient. He was, although fully recompensated, and his creatinine level was 105. He had an obvious systolic murmur and was referred to our institution. This was his EKG with a widened QRS complex, major anterior myocardial infarct. This is his left ventricle. Large akinetic end of the posterior wall, apex, anterior wall. There is some movement here. And you see his ICD coil right there. Now, for various reasons, this patient did not get the workup we usually do, because we would like to have an MRI, but this ICD prevents having an MRI, and that's actually the case in the majority of our patients. So that's the first problem. Second problem, I think this patient should have a viability scan or any proof that there is no viability anterior wall, but we couldn't do that in the short time that this patient was admitted. But if you see the coronary angiography, you'll see what the problem is. He had the right coronary artery, left system with a patent vein graft between these branches, but it was occluded to the aorta, and his Lima to LAD was patent. I hope you can see that with this light. His echo. There are still some basal segments contracting here. This is hypokinetic posterior wall, large akinetic apex. I think part of the septum is still working, but part is scarred. And these are not moving, but I assume you can see the problem of this patient. Some serious mitral regurgitation. Ischemic mitral or functional mitral with the akinetic or hypokinetic posterior wall retraction of systolic retraction of both leaflets, mainly in the posterior, but it's a central leak, so both leaflets were retracted. So his ejection fraction was 22%, MR grade 3, his TR was grade 2, pulmonary hypertension was estimated, PA pressure was 45, and his wall motion score index was 2.31. And I'll show you why we think that it's important. We've done analysis of preoperative predictors for bad outcome being early and 2-year mortality or recurrent heart failure symptoms, class 3 or more at 2 years. And these patients are in New York Heart Association class 1 or 2 at 2 years. This is the wall motion score index, and these are all the individual patients. And that did not go well. Okay. So the cutoff value, which can calculate with ROC analysis, is 2.19. But we believe that if you look at this gray boundary between a wall motion score index of 2.0 and 2.5, you see that patients below 2.0 are all doing well. Patients above 2.5 are all doing bad. That's probably not a good idea to operate on these patients. And between 2.0 and 2.5, there's this gray zone where you probably have to look for some viability or reserve capacity in the left ventricle. This patient was right in that gray border, and we thought that with revascularization of the posterior wall, he would recover and have a good outcome. His ICD reading and electrophysiological examination showed VT therapy before the operation was very easily inducible, so we thought he needed a ventricular arrhythmia surgery. So his operative plan was to do a CABG on the right coronary artery and the posterolateral branch, and use the venous graft to flow the remainder of the coronary system, surgical ventricular restoration, mitral valve repair, tricuspid valve repair, ablation of the border zone with cryotherapy, and implanting an LV lead to upgrade his ICD to biventricular ICD. Can you start the movie, please? So you're coming from this is the surgical side. We have the venous and arterial cannulas. Here we're on full bypass, normal thermic bypass with cardioplegic arrest, warm blood cardioplegia. There's been an electrophysiological examination. That's why the wires are here. And here you see that the anterior wall is falling apart. We are now clamped. We start to open the left ventricle, where we see the dimple of the akinetic or dyskinetic area. You see some scarring here in the inside. This looks like there is some viable tissue here, but you have to believe me that this is not functioning myocardium anymore. And if you look from the inside, you'll see how large the scar is. There's a left vent in the ventricle. We take out some bridging tissue to get a nice smooth area to put in the patch later on. If you want, we can stop the video at any moment if there's a question, because it's a movie about 13 minutes. So if anyone wants to stop the movie, I'll be happy to entertain any questions in between. So we'll do the exposure first with 4 retaining sutures. 4 retaining sutures, and then we inspect the extent of the myocardial infarct. So here we have the anterior wall. See all this scarred tissue. There's not much extension here, but on the septum it goes almost to the aortic valve. I'm trying to show here the posterior wall. It's hard to see, but we'll move the camera and I think you can see it a little bit better in a second. So first we do with balloon size. We have here the Chase mannequin. We'll put in the ventricle. We do that early in the operation to identify where the apex is going to be before we put any stitches in. And what I hope that you can see is that the apex of the balloon is well below or above the end of the scarring. The scarring goes down here. So we decided, this is not so great to see, but the scarring goes down below, but we will keep that little part of the scar in the ventricle and plicate the posterior annulus. That will happen in a second, but before we do anything, we'll do this cryoablation of the border zone. We found that only an endocardial cryoablation is not enough, so this patient gets endo and epicardial cryo. And we're still conducting a study whether this is sufficient to reduce the amount of ventricular arrhythmias after this type of surgery. From reading the ICDs, we found that about 25% of patients have therapy from their ICD after this surgery, so it's a significant problem. It's something we probably have to study more carefully in the future. So the balloon goes back to determine exactly the area where the apex is going to be. Here are application sutures, they start right there. It's a 2/0 Tycoon suture with a pledget on the end. It goes from approximately there to the other side here to plicate this area. That will aid in creating a nicer apex after the patch is placed. This is the beginning of the Fontaine stitch. Sometimes it's difficult to see where exactly the scarring begins because you can feel the thinning with your thumb and index finger, as you saw me doing that here, feeling where's the thin tissue here and where starts the normal muscle. Especially in patients that have thrombolysis, it's sometimes a mixed tissue there in the anterior wall. And you really have to feel where the thinning starts. So the suture will be taken all around here. This is exactly at the border zone between the scar tissue and what looks like the viable myocardium. This is a 0 proline running suture. So it goes exactly above this plication here. So the plication is going to be right underneath the patch. Pretty deep and thick bites in the ventricle. Before we tie it, we bring in the mannequin again, which is sized at about 55 cc's per square meter body surface area. And we tie now the Fontaine stitch over the balloon. And you feel with your finger that the stitch is really tight on the balloon. Now it's usually hard to get the balloon out, so you have to empty it. So this is the remaining area, and which will be covered by a patch. As you've seen, we have done nothing yet to the mitral valve. We'll do that later on. This bulldog here is on the patent memory artery, and I guess the venous grafts are already placed in the LV lead also. So the way I measure the patch is that I use just a ruler to measure the long and short axis. This is not so great. It's about 4x2 or 5x2. Make a long ellipsoid patch. This material is it's Dacron, and it's supplied with the balloon. We use a small rim that we're going to use as the area where we put our stitches. The stitches will be in the blue. And the way we do this, we use 4 2/0 proline sutures, beginning on the lower side, and then run them around the clock. So first stitch will be there. You get the second right there, the third is here, and the fourth start right there. this is a crucial part, is that if you're passing your suture, the running suture that will close this hole with the patch, if you pass it through the myocardium, it has to go around the Fontaine stitch, obviously. This is sometimes very good material to suture if it's scar, but here in this area there's much less scar and it can easily tear out, but if you have enough sutures and you go around your Fontaine stitch, you should be fine. So you run this in quarters. That's basically what I do. So this is done now. Goes well deep here on the septum. This is a little even deeper than you think it is. The movie, it looks like it's almost on the edge, but it's really deep in the ventricle, especially on this in this septal area. And you can see here the pledget of the suture that's creating the new apex. And it's hard to see, but this suture line will go above this plication of the posterior wall. These are the last sutures. Usually in this phase I stop the left vent, so the ventricle fills up, and you can see under pressure that the patch is tight and well positioned, no major leaks. We will close the ventricle afterwards, and one small leak is probably not an issue, but if you have two leaks, you start having flow behind the patch, which can be a problem, especially in terms of thromboembolism. So you really want to know that your patch is properly positioned and not leaking at all major spots. So there it is. And there are many ways of closing this ventricle. You can use enforced suture with filth, but in this case there was enough scarring here that you could use a primary suture line. What I'm using is a mattress suture coming from two sides. So beginning here, the mattress goes halfway, starting in the second suture on this side, coming to the middle, and then as a second layer do a continuous suture over and over. So this is where and what's important here is that you do not distort the patch, so stay away from the patch and really only suture this edge of the scar, because if you're too close to the patch you will distort it and it will ruin your reconstructed ventricle. So this is the second suture that will start on the other end of the scar tissue. This is actually probably the beginning of a myocardium that's reasonably viable. Looks very thick. The end of the two mattress sutures be tight here, and then this is already the running suture from the lower part going up. This is coming from the upper part going below. It's tight in the middle. And after this is done, we do a restrictive mitral annuloplasty. Well, you will talk about this in a second, right? Tricuspid, the LV lead, the bypass was already done, and so this was the end of the procedure. Can you stop the movie? Can I have my slides back, please? These are some post-op echoes. This is a TEE intraoperatively. It shows abolishment of the mitral regurgitation, movement of the septum. This is from before discharge, the left ventricle, and these are contrast-enhanced echoes. They're very difficult to see, but what you definitely can see that there is some dyssynchrony still in this ventricle. So it's the patient did not get his LV connected to his ICD yet, but by meanwhile he has. What's the next slide? So he had an uneventful recovery in intensive care, a little bit better actually than we expected because it was a high-risk patient that was already so long admitted for heart failure, and he was discharged to the ward on the second post-operative day. He was discharged to referring hospital on PO day 11, and he's followed up in the Mission Heart Failure Program, and he has been seen back in the outpatient clinic last week, and they'll schedule him for an upgrade of his ICD to a biventricular ICD pretty soon to get his synchrony improved. But this was a pretty uneventful course. Are there any questions about the...
Just before we have questions, I should have made an announcement earlier, I'm sorry. Those who want to go to the wet lab at 11:45, provided you've indicated that you want to go to the wet lab, you're very welcome to go. But if you're not signed up, you probably won't get in. So 11:45, we hope to finish this session, and there's a second wet lab on ischemic mitral valve disease. Thanks. Any questions?
Please.
I'm Hassan al-Sisi from Egypt. Why you didn't do the repair first before you do the... I would thought that you will start with the repair and then you will do the ventriculotomy. This is the second, this is my first question.
What do I do first?
The mitral valve repair.
No, the repairs after the ring is in. I don't want to lift the heart. So if I put in a ring, I do it after ventricular repair or bypass surgery.
Yeah.
So probably start with the left ventricular lead and the bypass, because therefore you have to lift the heart. Then do the ventricular reconstruction, and then the two rings.
Okay, and the second question, is there a possibility that you do the repair from the ventricular side, from the...
The ring from the ventricular side?
No, not the ring, just a suture from the one trigone to another, like...
The fontanus?
Yeah, I'm sure you can do that. I'm not sure whether it will work on the long term. I'm sure immediately you have an okay result, but the results of rings have been proven in so many patients, and we're a little bit worried that these patients do not tolerate the recurrence of their MR, so we want to have any chance that they get a recurrence. And with this kind of protection strategy, I mean, this is a long operation with a very long clamp time, but as you saw, they do fine.
Okay, thank you.
I think it's better to have the patient completely repaired with rings and bypass and ICD than do half the job. I don't think they tolerate that very well.
Any more questions?
Yeah.
What do you do for mitral valve regurgitation and papillary muscle in these cases? Do you have any plan for papillary muscle for the cases of mitral valve regurgitation and ventricular?
I think that's a very good point, and I think we should do something about the position of the papillary muscles. I'm not sure what yet, but maybe a sling or maybe a reconstruction that really takes care of the position of the papillary muscles. I think that should be another addition to this whole thing, but that also may be an interesting issue for functional MR anyhow, to do something to bring the two papillary muscles closer together.
Thank you.
Dealing with mitral regurgitation, I think they're really a very important issue, because mitral regurgitation is a marker of a bad ventricle. We know that because the transverse diameter is bigger. So we know that SVR by itself reduces some degrees of mitral regurgitation, particularly when the transverse diameter is not so big. Roughly, we can see that 1/3 of mitral regurgitation can be correct only by correcting the ventricle. The other big important issue is the recurrence of mitral regurgitation. And of course, different techniques can play a role, but the major role is the ventricle. So you know that I don't use ring at all. I have done 200 cases like that. And you use ring always as the majority of the... So I would like to ask you, which is the incidence of your recurrence of mitral regurgitation? I'm sorry, sir. You do. Sorry.
We don't want to steal the thunder too much from the last talk.
Yeah. No, I think Robert will show the recurrence rate. It's very low, but we have been very disappointing in the prediction of MR in the operating room. There were patients operated with grade 1 or not much MR that actually increased their MR after the surgical procedure.
One more question, I think, then we better move on.
Yeah. Thank you very much.
We'll go into that detail in the next talk. Okay.
Thank you very much, Dr. Othman from Damascus. I have a small experience in LV restoration, about 130 patients, but my question is about in acute cases and rupture of LV and pericardium.
This is a completely different issue. I have not done this in acute situation. We have operated on patients with relatively fresh infarcts, but acute, no.
Yeah. Just for
we had 2 patients with false aneurysm, but that's a totally different issue. What you're trying to do here is regain the function of the remote myocardium.
Yeah.
So it's a very different issue than the acute problem.
Really, I have experience in 4 patients. What I'm doing in this patient, I have many problems. First, to fixing the apex, because in the balloonoplasty we must fix the apex. Second point, fixing the end point of the on the septum. Third, how we can suture, because it's a fragile tissue. Really, we have four patients, and they are going very well in the same technique, in the same consequence of these patients. And the question is about mitral plasty of Mr. Lorenzo. In these patients, there is no, I have done nothing for the mitral valve, and he in operating room mentioned that there is no mitral leakage for the moment.
In acute patients?
In acute patient.
Yeah, but it's very unpredictable what happens in acute patient when he recovers. You don't know.
Yeah, thank you.
We don't see that many ruptures anymore. With primary angioplasty and PCI, we have it.
The problem, one of these patients after PCI.
I think it's too late.
Irving Kron, I believe he has a nice series now for acute patients.
Yes.
Yeah, that he's published. Yeah. Only one question, very technical point. At the very beginning, every surgeon was advised to check with the tip of your fingers where the contractility was ending, keeping and clamping the aorta during the time you open the left ventricle. Do you think it's really worth to do that with the image we have today?
It does help to feel where the thinning of the myocardium starts, and especially in patients with some mixed, a lot of these patients have mixed anterior wall after PCI, so you see some scarring, but you see also some scarring going into the entire ventricle. So if you feel, you sometimes really feel clearly where the difference is between the transition zone between the viable myocardium, there's thick muscle, and where it's very thin and there's no contractility anymore. But I don't do it on a beating heart or fibrillating heart.
Yeah, question related to this complex case, I would say. Scar removal, what's your experience with the removal of scar? That's the first question, as opposed to cryoablation.
Like an endocardial resection?
Yes.
I don't know. We have not done an endocardial resection, but we are a bit disappointed that after cryoablation of the endocardial zone, there still is a significant amount of patients with VTs after that procedure, so that's not effective enough. That's why we started a trial doing both endo and epicardial ablation, but I wouldn't be surprised if we have to go back to the classical endocardial resection to prevent that rhythm problem. And I raised this rhythm problem because we had a couple of patients that had their VT excitation site behind the patch, which was not, so the electrophysiologist could not reach it. I actually had to re-operate a patient after a door procedure who had a persistent site behind the patch. So I had to take out the patch, redid the entire reconstruction after endocardial resection. So it does happen, especially if you operate on patients with very large ventricles and end-stage heart failure. That's more and more a problem.
The last question. On the LV gram, it showed that there is a significant dyskinesia of the inferior wall, infralateral wall as well. And coming to the point of mitral valve repair, would an additional plication of that region help in approximation of or repositioning of the pap muscles? I mean, it's already a very complex case, but did you have the thought when you designed the procedure?
I believe that a repositioning of the papillary muscles may play a role in the future to get a better control over what's happening in the motion of the mitral valve, but at this moment I don't know exactly what I should do. The second point is it's disturbing if you do it after the procedure and you take off the clamp and you still have an MR grade 3 or 4, then you have to go back. So I rather just place a ring. And the third issue of dyskinesia should be treated